Assalamu alaikum wa rahmatullah. Today we are going to the principle of fracture fixation developed by AO. There's four main principles. First, fracture reduction, then fracture fixation to provide absolute or relative stability, preservation of blood supply, and early and safe mobilization. Fracture reduction is to restore the anatomy and the relationship between the two fragments of bone, or if there's multiple fragments between all the fragments, and this to return the affected part of the body to its normal position. And when we see there is displacement of the fracture, we look for two forms of displacement, translation or rotation. Translation can be in multiple planes, medial, lateral, posterior, anterior, or also it can be shortening or lengthening of the fracture. And when we speak about rotation, they can be internal or external rotation. They can be varus or valgus, malalignment, which is angulation, and then also can be flexion or extension malalignment, as appear in these illustrations. The aim of the reduction is either perfect or anatomical reduction, and this is required to restore the bony anatomy and the morphology of the bone. And we need this type of reduction when there is an intra-articular fracture, which need anatomical reduction. And this is not only intra-articular fracture, however, there's some long bone fracture which we need Oh, sorry, someone mute me. Okay. So there is we need anatomical reduction if there is intra-articular fracture. Also, there is some long bones like the radius and ulna. We consider them as one bone unit, and on these two bones we need anatomical reduction. Or we can have a functional reduction, and in this type of reduction, we need to retain the length, alignment, and rotation between the proximal and distal main fragments. So generally, when we're reducing the physical fracture, we need functional anatomical reduction, and in this type of reduction, we need to restore the length, alignment, and rotation. And this is basically we retain the bearing axis, load bearing axis of the extremities to be restored. And this is especially important in the lower limb. However, as we mentioned earlier, there's an exception for long bone fracture is in the forearm, which we need anatomical reduction in this bone, as we mentioned, because there is a pronation and supination movement, and this make it as intra-articular fracture. So if we go back for reduction of articular fracture, the joint surface is restored anatomically, and we want to avoid any gaps or steps in the articular surface. And when we may say gap steps, this means that there is no difference between the level of the two main articular fragments. However, the gap, if there is any two adjacent parts need to be near to each other. However, there is in some type of fracture we can accept some defect or gaps, and especially sometimes in the distal radius when there's very comminuted fracture. And after that, we restore the axial alignment. So that's what the first principle. The second principle of fracture fixation is of AO principles of fracture fixation is fracture fixation providing absolute or relative stability. And this depends about the personality of the fracture, the patient, and the injury itself. The goal of fracture fixation is to maintain the reduction, which we achieved primarily, and then to create an adequate stable stability, which allow early and optimum function of the injured limb, and also minimize the pain. The main goal of internal fixation is to achieve prompt and, if possible, full function of the injured limb. So if we had so basically if we can have a fixation and the patient can be mobilized straight away after that, that's our first aim, but this is not always possible. And to achieve this, there is two ways of fixation. The first type is absolute stability. And as we mentioned earlier, this we need it in interarticular fractures. And there is no movement where there's no movement between the fracture site. And this is we need for this very low strain, less than 2%. And this will lead to primary bone healing or intermembranous healing occur via Haversian remodeling and cutting zones. It's achieved by interfragmentary compression, and this can be achieved either by lag screw compression plate in absolute stability construct or tension band wiring. In this type of healing, there will not be any callus formation, and we achieve direct bone healing. And when we expand on direct or primary fracture healing, this occur under condition of absolute fracture stability by direct osteonal remodeling. And there is no callus formation, and there is primary healing occur even if there is minimal gap, and that's what we call the gap healing. And this is a microscopic photo shows this type of healing. And this is an illustration demonstrated more, where we can see that the osteoclast in the front of the cutting zone, which are present where there's new bone formation. And basically the osteoclast start to absorb or resorb the bone, and then followed by the osteoblast, which participate in the ossification process. And this osteoblast, when lie on osteons, get trapped and then become the osteocytes, which is a trapped osteoblast basically in the middle of the bone. Due to the activity of cutting zones, tunnels are cut through the compact bone, resulting in the creation of a new Haversian osteons in their walk. So, and this way, as can you see here, this is a fracture line, and then the cutting zone go from here to here. There is no callus at all, and then the bone heal in the primary bone healing. And to achieve this, as we mentioned earlier, we can achieve it by lag screw technique, or compression plate, or tension band wearing. We come for this later. If we want to achieve relative stability, however, this is happened by secondary bone healing, where there is a strain more than 2%. However, it's less than 10%. Otherwise, there will be no healing. If there is more movement more than 10%. There will be, as we mentioned, slight movement in the fracture site, and this response in the periosteum and external soft tissue to form endochondral healing. There is no interfragmentary compression at the fracture site. There is a callus formation, and there is indirect bone healing. And we normally use this type of healing in the physical fractures, where we don't need anatomical reduction. So in this type, we have relative stability, and this can be achieved by either splint or bridging. And example for this, intramedullary nailing, or internal fixation by plating, or external fixation. Sometimes we use a hybrid fixation, which is a combination between the two types of fixation. an example for this, if you can see in these illustrations, this fracture we show here in the scan, it's intra-articular fracture, however, extend to the metaphysis. And we achieve absolute stability around the joint. However, we bridge the comminuted part of fracture of the metaphysis, and this is hybrid fixation, which is absolute stability around the joint and then relative stability in the metaphysis, or sometimes in the epiphysis if the fracture extends to the epiphysis. Then to achieve the fixation, there is many tools we can use. We can use screws, plates, intramedullary nails, bridge plating, external fixation, or external splint, which is our normal cast. And to achieve this, all these have different function can achieve for us. So screws can be lag screws with intrafragmentary compression. Plate can be neutralization plates, buttressing plate or anti-gliding plates. The plates can work as a tension pad or compression plate, bridging plate, and one of these bridging plates can be a locking plate. Nails can work as internal splint. Bridging plate can work as splint as well. And external fixation was work as external splint, and the cast, as we mentioned earlier, can be a splint. So we start to speak about screws and their functions. So if we define the screw, it's a mechanical device which is converted rotational forces into linear motion. And there is different type of screws. There's cancellous screws, cortical screws, solid, cannulated, locking, non-locking, and headless screws. And each one can play a role in fracture fixation. Having a deeper look in the screw itself, it have a variety of parts. So the core of the screw, which is this yellow arrows, and this is the size which we need to drill to fix the screw to the bone. The outer diameter of the screw, that's the normal diameter we call the screw by. If we say 4.5 screw, we always mention this. This is the outer diameter of the screw, and we for that reason you find yourself when you start to fix or to use a screw. Sometimes you use, for instance, 2.5 drill. Sometimes you use 2.8, and you find the 2.8 work in the locking screws, which have a bigger core than the cortical screws. And then we come for the effective thread depth. And this is this area, this small area here, between the core and the outer edge of the screw. And basically, the function of this part of the screw is to how much grip it can get. For that reason, you find it bigger in cancellous screws if you compare it with cortical screws. And then if we look for the screw head, we can find that there is a standard head, that we can find locking head, and also we can find for variable pitch heads, which is can use in headless screws. And we mentioned the pitch of the screw. This is the area or the length travel with when there is 360 turn. So with each full turn, how much of the screw will go inside the bone, or how does the length go in the bone? And that's the function which is work when we have variable pitch screws. You find the head or the proximal part of the screw have a small pitch, and then we call it the shaft itself or the distal part have different, and then this make compression between the two fragments. And this is, for example, when we do fix our scaphoid fracture, and this achieve the compression on it, or fix the tarsal fracture. There's different type of tips of the screws as well. There's standard, and most of the one we use now is self-tapping, and also the self-drilling, which we don't use that much. So we come now for the Lago screw. It's very important. It's something we use every day in our practice. and it's very important to understand its function, or how you can achieve this function. So lag screw, there's lag screws by function, and there is lag screw by technique. So if you want to lag a fracture by, you need a lag screw, which is designed to be a lag screw. And this is a partial threaded screw. And then you have the thread to be in the far cortex, so we'll achieve compression. And lag by technique, and this is the most one we use normally in our daily practice. So this is normal full threaded screws, cortical screws. And however, the proximal hole or the gliding hole is drilled with the diameter of the diameter of the drill is the same diameter of the screw, so the screw wouldn't hold in the proximal bit, and we'll explain this a bit more. So to achieve these techniques, first you have to reduce the fracture, and then start perpendicular drilling. If you are using 3.5 screw, cortical screw, then you drill your gliding hole perpendicular to the fracture, and this only the outer diameter of the screw to the fracture line. So you don't cross the fracture line. Then through this hole, you centralize the drill by one of the sleeves, smaller sleeve for the 2.5 drill, and then you drill the far cortex. And importantly, you have to countersink as well, and this improves the screw bone load transfer, and then after that you measure after you do your countersink. And by this way, you have a gliding hole in the neocortex where the head is, so the screw wouldn't touch the bone in that area. However, it will hold in the far cortex. And because this is perpendicular to the fracture, then you achieve the compression and absolute stability. Other type of screw can be used for different things as well. Can be blocking screw. We'll speak about this more when we're speaking about nailing, and also can be, as we know all, it can hold the plates to the bone. Then we come for plates. It's another one of the tools we use in and out in fixing our fracture. So we have the DCB, or the dynamic compression plate. It can work as self-compression. Let's use this day, and the problem with it, it have a large footprint in the bone, and it compromises the osteum, and which compromise the blood supply. This has been evolved to the limited contact dynamic compression plate, and this is commonly used, and it can have the function for self-compression. And this self-compression function is according to the design of the hole. You have an oblong hole, and if you put the screw in eccentric way, when you compress this screw, the screw bone unit will move to compress the fracture. We'll speak about this more when we speak about the function of the plates. Then we have the locking compression plate, or the LCP, and this is very commonly used these days. It have a combi hole, which is have two areas, one for the locking screw and the other one for the compression screw, or the cortical screw. And the screw, the cortical screw can be tilted in different angle on that type of plate. Sorry, and this type of plate can be used in the different type of fractures, and also because it have locking screws, it have angular stability, which we used in the past to use plate and plate. However, now because it's locked to the plate as it locked to the fracture, it gives us very good angular stability. Also, we have the reconstruction plate, and we use this plate in different areas which around the joints, and also use them in pelvic fractures. And recently we have all these anatomical plates which can be used in complex anatomical sites, and normally it's LCB, it have an LCB component. We can use them to compress the fracture, and also because they have locking holes, it gives us angular stability rather. So this is the type of the plate, and then this plate have different functions as well. They can be used as a compression plates. They can be used as neutralization plate, buttressing plate, bridging plates, and tension band plate. Excuse me. So if we use the plate as a compression plate, this will give us, we are aiming actually for absolute stability. And this can be achieved by putting an eccentric hole, and this eccentric hole will, the screw then, when we compress the screw will slide to its neutral position, and with it we'll compress the fracture. And basically that's what we're expecting to happen. So if we put the screw eccentric in the far away from the fracture, then we compress the screw with the bone with it, it will go, it will move, and this movement hopefully will achieve stability. However, there's a problem with this. When we compress normally the fracture, there is, and the plate is anatomically contoured on the bone itself, there will be gap in the tension side. And to guard against this, what we can do, we can bend the plate about a millimeter or two in the center of the fracture. And when we fix the first side of the plate, this will have compression on the tension side. And then when we put our compression screw, then the compression all over the bone will happen. And this is a solution for this problem. Also, we can achieve the compression by using tension device. And to do this, we have to attach the loose fracture fragment. We have and to let it to go to the axilla. So basically, if the plate is here, then we fix one side, and then this have to be on an acute angle, and then this fragment will be compressed by pulling the plate into it, and this will achieve the compression, and then we can fix our plate. However, if you put your tension device in the oblong angle, the fracture will move and there will be malalignment, and this wouldn't work. So you have to create an axilla or an acute angle between the plate and the fracture. Also, to achieve compression, we can combine plate compression and lag screw technique. And in this situation, the only thing you have to remember is to compress the plate first, and then after that, do your lag screw. Again, the plate can be used as neutralization function, and the primary fixation will be achieved by lag screw, for instance, as in distal fibular fracture, in the ankle fracture, Weber B. And then this lag screw will give us absolute stability. However, if all the load come through it, there will be more movement because the load is bigger than the screw itself. However, we can put a neutralization plate, like 1/3 tubular plate, and this plate these forces will transmit through the plate and protect our primary fixation. Another function for the plate is used as a buttress. And some fractures are shortened and displaced under axial load, and we have to apply a plate in a way it buttress or the other fragment And this is the thumping it as you're pushing the fracture with the plate. And again, you can see here, there's an acute angle between the plate and the fracture, and this fracture is buttressed by the plate. An example for this is when in the tibial plateau fracture. So you can see this plate here is buttressing the fracture, not to go from the force which is coming this way. And this plate is buttressing the medial condyle, the force coming through the medial condyle to this part of the plate. Also, when we have a volar Barton fracture in the distal radius, this can be buttressed and with a volar plate, volar distal radius plate. And one can argue that even in this type of fracture, you don't need distal screws at all. Then another function of the plates is having bridging plate. And this used in combination with the very comminuted diaphyseal fracture. And this can be used to span the multifragmentary zone, which is have high energy zone, so you don't disturb the soft tissue. And through this plate, you can restore the length, the axial and rotational alignment. And as I mentioned, the goal of this use of this plate, you can use it through MEBO technique, and then you can preserve the biology of the fracture zone. And obviously, it doesn't give absolute stability, so the bone will have relative stability, and it will be a secondary bone healing. When we're using this type of plate or using bridging plate, also we have to remember that we have to use a long plate, and this plate should be about 2 to 3 times the length of the fracture itself. And also we shouldn't make it very stiff, because we are looking for relative stability. So so don't fill all the holes. And normally the number of holes filled is like 40 to 50% of the holes. And also basically 1/3 of them will be in the fracture zone, which is 30%, and then you don't fill the rest of the holes. Another function of the plate will be a plate can work as a tension band, and you can apply the plate to the tension side of the fracture, and this will give you full compression. A very example of this, which normally we don't use it a lot in the femur, however, femoral fracture, if you use the plate on it, basically because the force coming from the body through the neck and head of the femur, and this will give you a tension band, compression and tension compression in the medial side of the femur and tension in the lateral side of the femur. And if you use the plate in the lateral side of the femur, this will change the tension side to a compression side, and this will give you uniform compression all over the femur. Another way of fixation we use very common is nailing. So the nails or intramedullary nailing, they work as internal splint. They have indirect reduction, and they give us relative stability and abundant callus formation. And using the nails, we should establish the length, alignment, and rotation. However, we're not looking for anatomical reduction. Typically, we try to do them through minimal invasive technique. These devices are load sharing, and they are ideal for femoral and tibial diaphyseal fracture, and they can use for some metaphyseal fracture as well. There's very few points we have to emphasize when you are using IM nailing. First, the entry point. There is arthropoid varies according to the nail design. So even the femoral nail, there's different type of nails, which some of them use the piriform fossa and other one lateral. So you have to understand your device and how to use it, and the steps or the entry point for each device. The problem with incorrect entry point is it can lead to heterogenic fracture and fracture malalignment as well. And this is typically happens when your fracture is more proximal or distal. in the area of the flare up of the bone. Second point when using our nail, the reduction. So the nail itself is not a device to reduce the fracture. So you have to reduce the fracture prior to any fixation. So a nail will not reduce your fracture, and you have to maintain this reduction while you're reaming, and also because this will create the path for your nail, and also while you're inserting your nail. And to achieve this reduction, the reduction can be achieved by manual traction. So you can pull or push using crutches or anything to push the fracture to have the alignment you want. Also, you can use skeletal traction. This is not very commonly used. However, it come handy in some situation. And I remember using them when you have like amputees, and you need to, so below-knee amputation, and then you need to fix the femur. The only way to put the traction on it to put skeletal traction. The very common thing we use for reduction, especially in our femoral fracture, is fracture tables. And this fracture table, you have to understand your fracture table or traction table very well, because there's different position you can put the patient in. And so, for instance, this is a common position we use for our nailing. However, if you have a multiple injury patient, you don't need to lift the other leg, and you can put it in traction as well. And in some type of fracture, in femoral fracture, especially proximal femoral fracture, where your abductor is working and your iliopsoas is working, this deformity is very difficult to be reduced. However, if you use your traction table in the lateral position, this will become one of the easy operations you do. So you have to understand your traction table and how it can help you in reducing your fracture. Sometimes you can use one of the very good tools you can use is femoral distractor and or X-fix, temporary X-fix, or shunt pins, and especially in periarticular fracture, they are very helpful to do the ligament taxis for you and bring the fracture to a good alignment before you start fixing them. Some fractures are very known and very difficult, especially proximal tibial fracture and proximal femur fracture, and sometimes you need to open them up and use plating, and this plate you can leave it or take it after you put your nail, and this plate used just as a tool of reduction, and most of the time is unicortical plates. Blocking screws, they are a very important tool as well in your fixation. When you're using intramedullary nail. So when you use them for proximal tibial fracture, you have your normal deformity, which is tib anterior, and also valgus deformity of the distal part comparing with the proximal part. And then if you put a blocking screws, these screws will help you to reduce the fracture. But the most important, as we mentioned earlier, you have to put the screws while you are reaming, and then when you're putting your nail as well. So this will help you in reducing the fracture. Also, if you have any angular deformity, you can use your blocking screws to improve this deformity. And remember, you need to put this blocking screws in the concave part of the deformity. And you can see here, for instance, this femoral fracture. It's there's a varus deformity, and putting blocking screws or polar screws will help you to improve this deformity. And what we use as well, you can just sometimes you can get what you can use. You can use just a thick drill and like 3.5, and then you can do to guide your nail, and then you can remove them actually after you achieve your fixation. However, in these cases, if you're taking your blocking screws, what I would do normally, I will put my lateral to medial screws, and if there is an option, especially in the tibia, in the distal tibia, anterior to posterior screw, and this will help my rotation as well. One of the other important principles of fracture fixation is to preserve the blood supply. And to the preservation of the blood supply, this is to both the soft tissue and the bone itself. So always think in your approach, and also what device you're using and what technique you're using. And so to preserve the blood supply, this can start from when the patient arrived. So you have to be careful during transferring the patient and the position of the limb, because if there's a very severe deformity, this can affect the blood supply to the tissue, and then there will be irreparable damage. Also, you have to take care about the person or the injured patient himself, especially in elderly and young patient with when hypothermia can be a big problem. And so also during long surgery, you have to use like bear huggers or anything to warm your patient. Intraoperative, try to use atraumatic soft tissue forceps and retractor. You reduce the pressure on the bone elevator, so this will help not to destroy the blood supply. Use frequent irrigation of the wound. When you're not, if you're not using part of the wound, always cover it with a wet pad, and then select an implant and a reduction technique which doesn't interfere or interfere less with your blood supply. So for early and safe mobilization, this is one of the important principles as well. And early and safe mobilization of the injury part and the patient as a whole. And this starts from the post-operative care. So after the operation, elevate the limb after surgery in the upper limb elevation, and then avoid kinking the blood vessels. So don't flex the elbow more than 75 degrees when you put in a plaster or so. Also avoid the pressure area around the elbow, especially in the medial epicondyle with your ulnar nerve, and the fibula with your camporeal nerve. And when you follow up the patient, look on his x-ray, you want to pick up any problem with them, but in the same time, look at the injured limb itself. And if there is a pain or there is swelling and redness, this may be an early sign of instability and infection. And to achieve early mobilization, well, you can use encourage the patient to move the limb, the injured limb or the operated limb as soon as possible. And if you have your fixation, strong fixation as well, this can allow for early mobilization. You can use machine like the CPM. Also start weight bearing. You can even start with partial weight bearing, and give the patient adequate pain control, which can help him to mobilize as well. Don't forget that operation itself can lead to developing clots. So give thrombotic prophylaxis till the patient fully mobilized. And as we mentioned earlier, just try to recognize any complication early, as they can be treated easier. So the treatment of the patient wouldn't finish till he go back to his pre-operative capability, including his work, leisure, and function. Any questions?
Okay, thank you, Dr. Musab, for this nice, elegant lecture. And we can hear direct questions from the floor or comments from the other audience, such like the expert and expertise from other consultants or from the registrars. We can start first with the questions. from registrars and the residents. They can ask through the chat, or they can open their mic and we can listen for their questions.
Right.
Mr. Mahjoub رافع يده يا
Okay, we can give Mr. Mahjoub a chance until we hear questions from the residents and registrars. Welcome, Mr. Mahjoub. You can open your mic and talk to us.
طيب السلام عليكم ورحمة الله وبركاته.
ورحمة الله.
أنا سعيد جدا أسمع موضوع. كنت حريص جدا من أول دقيقة، كنت أول داخلي للمحاضرة، وسعيد جدا نسمع بعض غياب طويل، ونحيي كل الطيور المهاجرة لمشاركتهم، ودي حاجة جميلة جدا جدا، ونشكر كل المستحمين في البرنامج بقيادة بحاري كده.
الله يكرمك.
انا افتكر انه اجمل شيء في المحاضرات دي البرنسبلز، going back to principles. انا افتكر انه مهم جدا كل المحاضرات على كل التيتشنج سايتس يعني to restore back to principles. فشكرا جدا على المحاضره دي، انا استفدت منها كثير جدا جدا. وماي كويستشن في الريدكشن، انا افتكر انه واحده من الريدكشن تولز we don't use too much اللي هي using السبايكس او الهومان سبايكس دي في الريدكشن بصوره يعني elegant كده to reduce it reduce الفراكشر. الحاجه الثانيه المزعجه بالنسبه لنا اللي هي using حامل العظم، يعني ماسك العظم ده، ومثلا بيعمل السوفت ستريبنج for a long distance from the fracture site may lead to non-union وكده. ومرات الزول بيستخدم severely traumatic technique to devascularize the bone ends، وبيعمل مسطرة جميلة ومسمار جميل في الاكس راي، لكن السوفت تيشو ستريبنج ما بكون واضح للناس في الصورة حق الأشعة وكده. لكن أفتكر إنه one of the most important things to be considered always is soft tissue preservation near the fracture ends عشان البلس سبلاي وكده. أنا أفتكر دي نقطة مهمة جدا حق نركز على مصعب، لأنه كثير من الزملاء أنا لاحظت هذه صراحة يعني مزعجة بالنسبة لنا. they use very traumatic reduction tools زي ما فلو زي استعاض به بحاجة ثانية، بالذات في الفور ارم تلقى ماسك على العظم كده، تلقى كم سنتيمتر for both fragment near the fracture site، يعني bare from soft tissues، ما في أي soft tissue high bones وكده. فيا حبذا مصعب تركيزها على المحل دي، لأنه مهمة جدا جدا، لأن الناس sometimes fighting for anatomical reduction at the expense of soft tissue stripping. فدي مهمة جدا. شكرا لك مصعب مرة ثانية، وشكرا دكتور بحارج مع كل شيء.
شكرا مستر محجوب. يعني فعلا الحقيقة واحد سمع، يعني سعيد سمع صوتك وسعيد نختار المحاضرة زي دي. بعد نقطة حد الذكر عنها المستر حقيقة is very important point. ويمكن الكلام الكل في المحاضرة المختصر اختصار له إنه we have to preserve the blood supply للبون. And حتى if we see from the beginning the development of the plates themselves, it's always about how to preserve the blood supply and how become more friendly with the blood supply in the soft tissue. And also the way of reduction we mentioned, we spend time speaking about how to reduce a fracture. Sometimes you didn't, the problem with this very difficult fracture and the reduction is not very easy. However, if you used a different module of reduction, like the example I gave was a proximal femur fracture, when this proximal fragment is fully flexed and abducted, and you find the distal part of the fracture is pulled by the rest of the muscle. However, if you change your way of reduction and put the patient in a lateral position, even not in a traction table, and bring the distal fracture to the proximal fracture, this will help a lot. So زي ما قال مستر كامبو شوية حكاية الكلام, using the clamp, very big bone clamp to reduce the fracture. Sometimes this bring more harm than benefit, and you can achieve the same result with just change the way you reduce the fracture. احنا حقيقة باكين برضو يعني حاجة نركز عليها. احنا في السودان عندنا الفراكشر بتيجي very late والريدكشن حقها ما ايزي. احنا بنتكلم هنا مرات عن حاجات يعني when the fracture come 1 week later we thought it's very delayed. والواحد مذكر زمان في شغله في كنا في بحري femoral fracture يجيك لها زمن طويل جدا start to heal or malunited. وذكر واحد من التكنيك كان نستخدمه في الوقت ده انه you do the operation in 2 stages. You go in, you break all the callus, and لأن زي ما قلت لمستر حاول ترجع انت الفراكشر في اللحظة دي طوالي. You will strip all the fracture from the old soft tissue around it, but you just put skeletal traction and put the patient in skeletal traction for a week or so, give him some muscle relaxant, and come and fix the fracture in next week. After you have the muscle have been relaxed better and the fracture reduced better. يعني انا مثلا ذكرته ليه؟ لانه الانفايرمنت مرات على حسب الحته الزول شغال فوقها ما بتكون كل يعني البيشن ما كلهم بيجوا يجوا الواحد بعد ما يكون مش البصير وعندهم لونج جيرني month or so حتى يجوا للدكتور وهو يعني face with a big problem at that point.
Okay, we can hear questions from the floor. لو في أي زول عنده مشاركة داير يشارك.
السلام عليكم. أنا شكلي أكون طويل عشان كده بس بطريقة متعددة قبل ما يظهر سؤال. أول حاجة ما شاء الله مصعب يعني محاضرة is so nice and so organized. It's full coverage of the topic in a very nice way. I think إنها محاضرة حتكون مرجعية لأننا في أي لحظة الواحد يحتاج للطبيب ده يرجع على كلامنا يعني لأنه مكتوب بطريقة حلوة جدا. حاجة واحدة بس حبيت أعلق عليها بالنسبة للريجسترارز اللي هو إنه نحن for very long time حاسين إنه الطريقة اللي بيحصل بها البون هيلينج اللي هي دي واحدة من الجسم المفروض نكون فاهمينها إنها if you don't understand it you will mess up a lot of fractures. يعني going retrospectively and looking at the cases we have done many years ago and why they didn't heal we couldn't understand even why يعني. فواحدة من الحاجات اللي كانت مهمة الواحد بجد كانت يعني life changing في البراكتس بتاعه إنه understand البيرنج ثيوري بتاعت السترين ثيوري. وأنا ما أعرف هل الريجستراس understanding الحاجة ولا أنا عارف إنه الناس الليفل بتاعها lot better than what we did before يعني. فبس حبيت أشرح شوية يعني إنه الراجل اللي اسمه بيرنج ده لما جاء what's interesting about الأوستيوبلاست إنها قدر الانفايرمنت اللي انت بتديها لها بتاعت السترين اللي هي المايكرو موفمنت بين الفراجمنت والفراكشر عندها ميكانو ريسبتورز. الميكانو ريسبتورز دي بتخليها انها to produce different tissues according to the movement micro movement. فبيرنج لما نطلع الثيوري بتاعته نتكلم عن انه لو الموفمنت اللي هي السترين اللي هي النسبه بتاعت الحركه الموجوده بين المسافه الاصليه والحركه اللي بتحركها العظم إذا كانت أقل من 2% دي بتديك برايمري بون هيلينج. يعني شنو برايمري بون هيلينج؟ يعني ما في كلس فورميشن. يعني البون حيفهم إنه أنا ما محتاج إنه أطلع كلس لأنه أصلاً ما في فراكشر وحيهيل طوالي بكاتنج كونز. عشان كده لازم الناس تفهم إنه في البرايمري بون هيلينج ما في كلس أصلاً. لما تبقى الموفمنت أكتر من كده because it's so intelligent cells حتكون تنتج كلس. الكلس ده كان يثبت العظم يحرك لنا الانفايرمنت من 10 اللي هي من 2 ل 10 دي بتعمل لك من 2 to 10% بتعمل لك كلس. خلاص. فالكلس هو مرحله يعملها مرحله يعني intermediate step عشان يقدر في النهايه produce primary bone healing برضه يعني اللي هو عن طريق الريموديلينج. فالسكندري بون هيلينج هو عباره عن مرحله انه لانه ما حيقدر ب very mobile bones انه to heal، فحيقوم to lay down callus، وده اللي حنشوفه في الاكس راي خلاص. وبعدين it will remodel to primary يعني cutting cones وكده. فالحاجه المهمه انك انت you have a lot of options in front of you and you have a patient in front of you. يعني البيشنت اللي قدامك ده انت مثلا عندك very commonly femoral fracture اصلا you cannot achieve primary bone healing في ده. So you have to be يعني very logical in your thinking and how you're going to fix this fracture. As مصعب يعني explained الحته دي very nicely انك انت the most important priority بالنسبه لك هنا is to preserve the blood supply. So that's another كلمة عن الميبو technique وانه to slide plate without any dissection and to do bridging plate وto create a working length طويل بالنسبه للبليت عشان تقدر تكون في مايكرو موفمنت وما تعملها very rigid construct، لانه انت محتاج للمايكرو موفمنت between 2 to 10% عشان to produce colors. ف the choice of the implant plus the choice of what you have in your hand, what available, what your equipment's available for you, that's all give you the option that you choose the right option to get it right first time.
شكرا محمد على التعليق.
There is a question from Dr. Elgalli تقريبا في الشات، ممكن دكتور مصعب يشوفه ويرجع عليه، اللي هي بتسأل sequelae of using lag screws without countersinking.
طيب if you use a lag screw without countersink, the problem will be that this part of the head is contact with the bone, and this will make more pressure on the bone, because as you know the pressure is the amount of force per centimeter square. So if you have like a bigger area for the head to work in, it will make less pressure on the bone and then less possibility of fracture. The other thing, when you use the countersink, sometimes the lag screw, because you have to be 90% to the fracture itself, sometimes interfere where you put your neutralization plate. So if you put that countersinks, this will give better profile for the plate, even if it's near to the side of the screw.
Okay, thank you. Is there any question? Other questions? Or any comments? Okay, if there is
لو ما في سؤال يا ابو حار، احنا عايزين نسال حقيقه انه يعني ما عارف عارفين احنا طبعا احنا زمان زمان كان عدد حق حضور الليله دي يكون عدد كبير شديد، لان كان الدفعه بتاعتنا 4 انفار،